In the last session, we have discussed about the antipsychotics and mechanism of action. Today, I will be discussing the side effects of antipsychotics on an MCQ basis. So, let us start with the first question. Which of the following antipsychotic medication is most commonly associated with the sedation? The options are risperidone, aripiprazole, olanzapine, and quetiapine. The sedation is a side effect which is due to the histamine blockage. So, in addition to the D2 blocker, antipsychotics have action on various receptors. One among them is the histamine. Olanzapine is having maximum incidence. Of course, quetiapine also. So, the correct answer is olanzapine. So, when you start patients on antipsychotics, remember sedation as a separate side effect. A 45-year-old male patient, a known case of schizophrenia, is started on a new antipsychotic medication. After a few days of treatment, patient reports lightheadedness and dizziness when they stand up. Which of the following medication is most likely responsible for this? So, standing producing dizziness is consistent with the orthostatic hypotension. So, orthostasis is a side effect of antipsychotics and it is due to the alpha blockage. Alpha blockade leads on to vasodilation. And indirectly the question is, which drug is having maximum alpha blockade? Aripiprazole is a drug which has got partial agonistic action. So, it is unusual to produce orthostasis. Among the other, clozapine can produce, but it is well known for agranulocytosis rather than orthostasis. Haloperidol has got a lesser incidence of orthostasis, and the correct answer is quetiapine. So, you should be careful in starting quetiapine in elderly patient because it can produce orthostasis. Now we go to the next question. A 55-year-old male patient diagnosed with schizophrenia is initiated on a new antipsychotic medication for the management of psychotic symptoms. After a few days, he complains of dry mouth, blurred vision, and constipation. He has got difficulty in passing urine also. Which of the following antipsychotic medication is most likely responsible for the side effects? As mentioned, antipsychotics can act on the muscarinic receptors. And dryness of mouth and other things are due to the anticholinergic action. So here, which is the drug which is more likely to produce anticholinergic action? We already mentioned aripiprazole, unlikely. Haloperidol has got less chance. And the remaining two drugs are the clozapine and ziprasidone. So clozapine is associated with the higher risk of anticholinergic side effects, including dry mouth. So clozapine can produce agranulocytosis and a very high incidence of anticholinergic action. Haloperidol is not typically associated with the prominent anticholinergic side effects. Now we go to the next question. A 40-year-old patient is started on antipsychotic medication, and the clinician should be vigilant on metabolic issues, including significant weight gain and glycemic abnormalities. So, when somebody has got features of metabolic syndrome, which of the following antipsychotics you should use carefully? That's a question. The metabolic effects are mainly due to the 5-hydroxytryptamine, especially 5-hydroxytryptamine 2C, actions on the histamine, lack of exercise or lack of activity, and various other factors also contribute to obesity. 15% of patients on olanzapine can develop diabetes. So dyslipidemia and hyperglycemia are major side effects of olanzapine. So among the antipsychotics, maximum incidence of metabolic syndrome is associated with olanzapine. So should be careful when starting patients on olanzapine. You have to check the BMI and blood sugar. So olanzapine can lead on to significant weight gain, dyslipidemia and glycemic abnormalities, and this will increase the cardiovascular risk. So cardiovascular risk is not only due to arrhythmias but also due to the metabolic effect also. So look into this picture, we can see most of the antipsychotics have got other side effects, especially the atypical antipsychotics. They act on the 5-hydroxytryptamine receptor, M1 and M3 anticholinergic action, alpha receptor producing postural drop, sedation due to H1 receptor, D2 the extrapyramidal side effects. Now we go to the next question. A clinician treating a patient with history of seizure with antipsychotics. Which class of antipsychotic medication should be used with caution in this patient due to the potential risk of developing seizures? The antipsychotics, in addition to the receptor blockade, have got some membrane effect. Typically is the potassium channel, and the membrane effect can lead on to precipitation of seizures also. So the options are first generation antipsychotics, second generation antipsychotics, clozapine, low potency first generation antipsychotics. The correct answer is first generation antipsychotics. So first generation antipsychotics, especially haloperidol and chlorpromazine, are well known to produce seizures. Now we go to the next question. A 35-year-old male with a history of schizophrenia is prescribed antipsychotic medication. After several weeks of treatment, patient presents with syncope and palpitations. Which of the following antipsychotic medication is most likely responsible for arrhythmias? The options are risperidone, olanzapine, quetiapine and ziprasidone. So the correct answer is ziprasidone. The first generation antipsychotic thyroidazine significantly prolongs. Ziprasidone is also associated with QT interval prolongation. The atypical antipsychotics have got lesser chance of producing, and there are not much reports of QT prolongation and torsades pointes. So one of the arrhythmias that occur with prolonged QT interval is the development of torsades pointes, that is multifocal ventricular tachycardia. Risperidone has got a lesser risk, olanzapine has also lesser risk, quetiapine is also lesser, that is most of the atypical antipsychotics are associated with lesser side effects. First generation drug, thyroidazine is having maximum. When the QT interval is more than 500 milliseconds, the risk is very high. So now we look at which are the drugs which are potential for producing QT prolongation. So we can see that the typical antipsychotic, thyroidazine, haloperidol, chlorpromazine have got very high incidence. Atypical antipsychotics, ziprasidone, remember quetiapine. These are the two drugs among the atypical antipsychotics. Psychiatric illnesses have got a risk of development of QT prolongation and arrhythmias. There is no drug with zero risk. So, in short, when you are treating patient with multiple risk factors for arrhythmias, electrolyte imbalance, family history, coronary disease, be careful to take an ECG and look for QT prolongation. So one word regarding the QT prolongation. So you remember the cardiac action potential. This is a repolarization, and this is due to potassium current. Antipsychotics can block the potassium current and prolong the QT interval. This is the QT interval. This is prolonged with potassium current blockage. So now we go to the next question. A 34-year-old patient with schizophrenia started on new antipsychotic. Patient complains of inner restlessness and difficulty in remaining still. That is, there is a physical and mental restlessness. Patient has got tremulousness of hands, masked facies, and shuffling gait. That has got extrapyramidal features. Which of the following intervention is most appropriate to manage these symptoms? The feeling of internal restlessness. That is, a patient has got a feeling of restlessness, not only physical but also mental. This is called akathisia. So the answer is given. Increase the dose, of course it is wrong. Add a low dose beta blocker. That's correct answer. Discontinue, but it may not be possible. So add a low dose of beta blocker is the current management strategy. So there are different ways of managing this. One is reducing the antipsychotic dose. Second, adding or adjusting an anticholinergic medication. Third, giving a beta blocker. Fourth, giving benzodiazepines. D2 blockade is the main reason for the action of the antipsychotics. When the D2 blockage is between 60 to 75%, it has got antipsychotic action. More than 75%, it produces extrapyramidal symptoms. So when the receptors are blocked, more than 75%, you get the extrapyramidal effect. So remember this point. So D2 occupancy is an important thing in considering many of the side effects. And the extrapyramidal features are due to the D2 blockade. A 42-year-old patient with a history of schizophrenia has been on hypertensive first-generation antipsychotics. He presents to the emergency department with hyperthermia, autonomic dysfunction, coated mental status, and muscular rigidity. So this is the neuroleptic malignant syndrome. So neuroleptic malignant syndrome is characterized by mental status changes, autonomic dysreflexia, hypertension, tachycardia, incontinence, sweating, etc. and muscular rigidity extrapyramidal. Two important lab findings are: one is elevated CPK and second is the leukocytosis. This leukocytosis is not due to infection, it is a stress-induced leukocytosis. Question is, how would you manage this? One is administering more of the current antipsychotic. This is a wrong answer. Discontinuing current antipsychotics may be effective. Administering high dose of benzodiazepine, not the drug of choice. Administering a dopamine receptor agonist such as bromocriptine. So these are the two options we have got. So neuroleptic malignant syndrome is a idiosyncratic reaction, and this might develop after 2 weeks to 20 years. So later also you can get NMS can occur after several years of treatment. By changing the dosage, increasing or decreasing and rate is a rare effect, 0.5 to 1%, and potentially fatal. Mortality is 20%. As mentioned, it can present with mental status changes, high fever and autonomic instability, muscular rigidity, and two investigations we have said: stress leukocytosis, elevated creatine kinase. So the treatment of choice will be discontinuing the current antipsychotics, and you may start the patient on bromocriptine, and dandrolene is another drug which is useful. Which statement is correct regarding the use of atypical antipsychotics? They are effective only for the positive symptoms. They affect only the negative symptoms. They cause more extrapyramidal symptoms. They commonly cause weight gain. Atypical antipsychotics are effective for positive and negative symptoms. So these two answers are wrong. And we have explained the reason why that is effective for the negative symptoms, because the decrease in the mesocortical pathway, dopamine, is the reason for the negative symptoms, and the atypical antipsychotics have got a partial agonistic action. Because the serotonin blocks the release of dopamine. So when the serotonin receptors are blocked, naturally the dopamine level increases. They cause more extrapyramidal symptoms. Is wrong because The atypical antipsychotics have got a loose blocking, and so the side effects are less, extrapyramidal less effect. They commonly cause weight gain, that is the correct answer. So atypical antipsychotics are notorious to produce weight gain. This we have discussed earlier. So we have discussed about the various pathways concerned with the, just recap, this is a nigrostriatal pathway concerned with extrapyramidal features, the mesolimbic pathway for the positive symptoms, defective or decreased action of the mesocortical pathway leading on to the negative symptoms, and the tuberoinfundibular pathway concerned with the secretion of prolactin. So blockage of dopamine in this pathway leads on to release of prolactin, hyperprolactinemia, and can produce sexual dysfunction. So today I have discussed about the major side effects: sedation, neuroleptic malignant syndrome, acute dystonia and tardive dyskinesia we will discuss in a later time. Prolactin secretion, orthostatic hypotension, sudden death and QT prolongation, the metabolic syndrome, agranulocytosis, and anticholinergic effects.